Hello, my friends, again after the record. So we have intrauterine contraception TOG article, which one of the most recent TOG articles about the intrauterine contraception. Okay, it was published July 2021. Okay, and here there is a percentage of women with an unintended pregnancy within the first year of contraception use, or we can call it the failure rate, okay, of the contraception method, different method of contraception. The good thing, very easy thing about the contraceptive method, actually, that we will see that in every TOG article, my friends, they give you like a full review of the contraception, like we are revising the contraceptions again. Okay, so it's very easy, okay, and interesting. Okay, so at the beginning, shall we confirm that the voice is audible? Is it clear for you guys? Okay. Okay, good. So my friends, here in that table, we will have a difference between the perfect use and the typical use. What is the perfect use of the method? I will tell you, this is the theoretical effectiveness, okay? This is what should be like the manufacturer, they say about themselves that this is a failure rate, this is a pass rate, and all. Okay, typical use, this is a real world effectiveness, or this is what happened with the users, okay? Because so many methods, actually, it can be affected with some circumstances, and we call it the user dependent, okay? So this is the typical use, and this is the one that we counsel our patient about it, okay? So you can see here, number one, what is the most effective method? Okay, it's very clear in this table if we compare between the method and each other. Which method sounds like most effective? The method with the least failure rate. And the method with the least failure rate is the progesterone subdermal implant, right? So we are still there, good, okay? Just confirming the information. And also you can see that it had no difference between the perfect use and the typical use, right? Okay, so again, let's see another method that sounds very effective here with failure rate of 0.1, okay? Like which method? Like the vasectomy, okay? So even if a couple, they want to discuss sterilization together, okay? Our counseling will be that the failure rate of vasectomy, okay, was quoted to be 1 in 2,000 for the male, okay? And here in the first year, it's 0.1% only, okay? But if we say about the LARC, or a method of the long-acting reversible contraception, like the implant, is even more effective than a male vasectomy, a male sterilization, 0.05. Okay, my friends? So they give you questions about the progesterone subdermal implant is the most effective, okay? If we speak about the Mirena, okay, what is the theoretical effectiveness? It's the theoretical effectiveness is 99.8, and the failure rate is 0.2%. Failure rate for the typical use is the same as the perfect use, okay? So that's mean it's very effective, and it's not user dependent, okay? So you insert the Mirena for the woman, and that's it, okay? Okay. Copper ID is 0.6 as the perfect use, okay? This is the failure rate, 0.6, and the typical use is 0.8, okay? Then by injection, okay, the injection is 0.2, right, %. But The typical use is 6%. That means there are mistakes in the use of DIMBA injections or not, depending on the users. Yes, okay, so it can be affected. Look to the progesterone-only pill, 0.3, but here 9%. That's very high failure rate. That's almost 1 in 10, right? And combined hormonal contraceptive, the same thing. And this is because it's user dependent, because you are depending on the woman every day to remember her pill, right? Condom is 2% of perfect use and 18% with the typical use. Okay, some factors like the user dependent factors, okay, use of spermicidal cream can lead to theoretically it increases effectiveness, but you know, sometimes it's slippage or rupture of the condom, use of other lubricant or creams, or even therapy like the clindamycin cream or the clotrimazole cream as well. Okay, all of these can affect, you know, the effectiveness of the condom. So it's 18%. Look at some other methods. No, Dr. Iman, it's not perfect use, it's not the same. This is the failure based on the theoretical effectiveness. Okay, perfect use is the theoretical effectiveness of the method. And here we speak, the table say the failure rate. So a little bit of, you know, concentration will be fine. Percentage of women with unintended pregnancy. This is the failure rate of a method. This is the theoretical failure rate when I say perfect use. When I say typical use, this is the real world effectiveness. Okay, so this is that's what happened in practice, what happened in real life. Fertility awareness method failure rate is 24 with the typical use. Okay, the no contraception at all, okay, is associated with risk of pregnancy 85, right? Which is not a method. Okay, my friend. So let's speak about the intrauterine system, and this is the aim of the discussion of today. Okay, so first they start with the longest levonorgestrel containing intrauterine systems, and the 4 branded available in the UK is Mirena, Jidus, Kylena, and Levocert. Okay, okay. So the Mirena is very famous. Okay, and the Jidus and Kylena also are famous as well. But the most important thing about the Mirena that we always remember, its use for the treatment of HMB, okay, and for endometrial protection as part of menopausal hormonal therapy, right? So Mirena has other uses than using it as a contraception. And it can be used for how many years? If we speak about contraception, it can be used for 5 years. If we speak about heavy menstrual bleeding treatment, 5 years. But if we speak about its use as endometrial protection as a part of hormonal replacement therapy, this is 4 years. Okay, guys? Jidus is effective for 3 years, Kylena for 5 years. Levocert, licensed for contraception and HMB for 5 years as well. Some notes that can come in the single best answer questions, okay, about the release of the daily release of the Mirena per day, okay, is 20 microgram of levonorgestrel, okay, which gradually reduce over time. By the way, this is oral exam question, okay, and single best answer exam question as well. Okay, the other types like the Jidus and Kylena, they actually release lower doses of the levonorgestrel per day. The mode of action of IOS is to thicken the cervical mucus, prevent the sperm penetration, thin the endometrium, and possibly also a foreign body effect. Ovulation is not usually inhibited, and estrogen level remain the normal physiological range. Levocert is currently the least expensive, okay, one, and Levocert does not have a license for endometrial protection. Remember, it's contraception and HMB. Jidus frame and also the Kylina considered smaller, and insert tube is narrower compared with the Mirena, okay? And women may experience less pain on insertion. So if you have a woman, she comes to you for contraception and she wants the hormonal one, it's better to advise either the Jidus or the Kylina, right? If you have a woman and treatment for HMB, so which one you will use mainly? For treatment of HMB, you can use the Mirena or the Levocert. The advantage of Mirena is that it can be used also as a part of the menopausal hormone therapy for endometrial protection. Okay, and Mirena also can be used in the treatment of endometrial hyperplasia. So for the pathological problems, Mirena can be very helpful. If we speak about contraception only, Jidus and Kylina, okay, because they release less progesterone in blood per day, okay, and they are smaller, okay. The inserter tube is also smaller, so it's more comfortable to the woman and less painful during insertion, okay? Okay. Side effects and common issues. Problematic treatment usually will settle in the first 3 to 6 months. After 1 year of use, lighter periods are common. Up to 20% of women experience amenorrhea, okay, with this method. After 1 year, okay, so the bleeding, if it's there, it will be very light, or it's in some women, 1 in 5 will stop having menses. Return to fertility is not delaying following removal of the IUS, okay? And hormonal side effects like headache, bloating, acne, and breast tenderness, but this is usually settled with time. Weight gain has been observed with the methods as well, okay? And I would like to say that some women can be affected in their sexual desire, okay? And some women can be affected in their mood. And some women who are very sensitive to the progesterone may find that the side effect of the, even the local hormonal IUS, okay, is very severe for them, okay? So carefully choose your patient, especially patient with severe PMS, for example, or the patient who experienced depression when she used the progesterone only method, okay? So be careful, okay? Be careful when you use this method. Okay, my friend. Okay. Here we speak about the eligibility, okay? The eMRCOG. If a woman had breast cancer, currently she had a breast cancer, do you think that we can insert the intrauterine system? We can give her anything that contains progesterone? No, we can't. Why? Because it's 4, right? Past history of breast cancer, she had a breast cancer and treated, that's make it category 3, okay? And the category 3 means that risk usually outweighs the benefit, so it's not preferred. Copper intrauterine device. Okay, some interesting information about the copper. I know, sorry guys, that we are dealing with some basic information, but sometimes you need to just read them and, you know, arrange things in your mind. So the gold standard copper intrauterine device contain the 380 copper, okay? And this is on the stem and arms of the device. Copper affects sperm motility and cause white cell infiltration in the endometrium, and this is rendered the environmental hostile to implantation. Complications at the insertion are the same as the IUS, and use is not contraindicated because of age or parity. Intrauterine ball, okay, this is produced in Israel, Okay, so recently became available in the UK. The device contains 300 millimeter copper, okay, shape memory. And this is have also a copper pills. It's smaller than the T-framed copper IUD and comfort the shape of the intrauterine cavity. Okay, so this is the use of the intrauterine ball. Once the intrauterine ball released from the 3.2 millimeter diameter insertion tube into the uterus, it coils into the spherical shape measuring 15 millimeter in diameter. Okay, so here, my friends, comparison between the diameter of the insertion tube, which can be, you know, sometimes you can look at it to have an idea about the diameter, okay? And you can choose it for your patient, which one has the least diameter, especially if your patient is nullipara or your patient, she didn't deliver vaginally before, she had problems, okay, with the cervical tightness or something like that. Some patients are anxious when you insert to them. So you will find that the Nova-T, okay, had the insertion tube 3.6, okay? So if you compare between the insertion, diameter of the insertion tube, which one is the smaller? The smallest is the Nova-T, okay? The Nova-T 380. So it's easy during the insertion, right? Okay, so followed by Gydus and Kylena, 3.8, okay? And here, by the way, also the duration of use, the license of use for each one of them. So if I told you about the copper T 380, this was a previous single best answer question. So what is the duration of use of it? The copper T 380. Very famous, 10 years. Okay, so what if I told you Nova-T? Nova is not the same as the copper T. Nova is 5 years, right? So it can be a single best answer question because they asked about the copper T before. They asked about the uterine perforation rate, okay? And the uterine perforation, both for the copper IUD and the levonorgestrel, are associated with very low rate of perforation, 2 in 1,000. Could you please remind me before which numbers that we have studied that was overall complication 2 in 1,000? Yes, in use of the laparoscopy, yes, and the hysteroscope as well. Yes, serious complication, overall complication is 2 in 1,000. Okay, the perforation rate increased 6-fold in the postpartum woman, especially breastfeeding. Okay, there is no evidence of increased perforation rate between removal of the placenta and 48 hours postpartum. Okay, this is include post-vaginal delivery or insertion immediately post-cesarean insertion. Okay, guys, so there is no difference, as you can see here, or no evidence of increased perforation rate between when you insert it after removal of the placenta up to 48 hours, okay? So you know that from 48 hours to 4 weeks, we don't insert it, right? Because of increased risk of the perforation at that time. Expulsion, the risk of expulsion is around 1 in 20 and most common in the first 3 months after insertion. Okay? Okay. Cervical shock. So a small number of women experience bradycardia 1.8 and hypotension 2.1 when their cervix is stimulated at the time of the IUD insertion. In most cases, lowering the head at the bed and administering oxygen is sufficient to support recovery. If the bradycardia is less than 40 beat and is sustained, the drug of choice is 500 to 600 microgram of atropine, delivered ideally intravenous. This can make very interesting question in your exam. How to treat sustained bradycardia after the IUD insertion. Okay, that result from the cervical shock after the IUD insertion. If it is sustained, okay, if it is sustained, then use a drug. Initial management for any case who had bradycardia is to lower the head and give oxygen. But if the bradycardia less than 40 or sustained, so in this case, we will give atropine. The doses of every drug is important and the route of administration. So 500 IV, okay, of the atropine. Also, intramuscular can be acceptable if the intravenous access is not possible, okay? Okay. Pelvic inflammatory disease, the risk of ascending infection when the IUCD is inserted in a woman with bacterial sexually transmitted infection, okay? But the risk of pelvic inflammatory disease developing is low. So there is risk of ascending infection, right? So if the woman carry infection, okay, there is risk of ascending infection. Be careful of this recommendation, okay? But risk of the pelvic inflammatory disease is overall low, and it's only 1.6 in 1,000. Okay? Okay. If the woman developed PID, we don't remove the IUD immediately. We actually give antibiotic, okay? And we wait for a good response. If there is no improvement after 72 hours, okay, then in this case, we will take the IUCD out. Some ladies or some people in their practice, what they do is they found that the lady had infection, maybe related to IUD, maybe not. They remove the IUD to treat the infection. Is that correct? Or they tell them, you have infection, and infection can be vaginally, okay? There is a difference between lower genital tract infection and upper genital tract infection. Upper genital tract infection like PID, like ovarian abscess is very serious, right? Because it can go to sepsis. It can, turn into sepsis. And that it has complication and effect on fertility. But lower genital tract infection, okay, can be treated, easily. So why to remove it? Right? So it's not correct that you remove the IUD even if there is PID. If there is PID, this is a complicated infection. However, we give antibiotic a chance for 3 days. Okay? Guys, please give me 1 minute, please. So Dr. Iman is asking about the need of condom. You mean the need of condom with the infection, with the treatment infection? According to which infection you are treating, but it's better, okay? As we said before in the STDs, okay? Not all the infections, we advise abstain from sexual activity, okay? But some of them are very important, like what? Like, for example, if the patient had M. genitalia, right? Okay, this is one. What if the patient had trichomonas vaginalis? We advise that the couple actually be treated and they abstain, right? Okay. If there is PID, abstain, of course. Abstain. It's not about that the sexual intercourse is allowed or not. Okay, it's not about the use of condom, it's about abstain from the sexual activity. So this will make the infection even worse, especially in a case, of course, of a PID. the use of condom at the time of infection, okay, it can make things worse because of the irritation that caused by the condom material. Condom is used as a protection from STI, especially in a society where they have, open relationships. Okay, so we advise them, we gave them a safe sex advice that if you have sex, okay, then it's better, especially with a stranger, of course, it's better that you use condom to protect yourself from STI and HIV, right? But if you have a complicated STI, please treat it, okay, and advise abstain from sexual activity till the treatment is complete. Okay? Okay. Ectopic pregnancy. The overall risk of ectopic pregnancy is reduced in association with the IUC, okay? Use versus using no contraception. How? I'll tell you, okay? Because they compare if the woman didn't use any contraception and she got pregnant, what is the rate of the ectopic in this case? In a woman not using any contraception. And they compare if she used the IUCD, okay, what is the rate of ectopic if pregnancy happened? Okay, and they found that the number of cases that would develop ectopic when there is no contraception is more, right? Because the pregnancy rate is more. That's it. But to be honest, again, this is a political, statement, right? This is a political statement. We all know that if a woman is using intrauterine contraception and she got pregnant, there is high risk that this pregnancy can be ectopic, right? Is that correct? But this should not be communicated as a contraindication or for the people that they be afraid of using the contraception. Because what is the failure rate of this method? Can you remember? Yes, Dr. Samah, I like that you answered the typical use, right? Okay, so if we speak about the typical use, what will be the risk? 0.8. Okay, so if it is 0.8, my friend, okay, so that means the risk of pregnancy itself is low, very low actually, right? So among the cases that will have unintended pregnancy, there is a risk of increased ectopic, but of course there is other complication also, okay, of getting pregnant on the IUD. Right, right. Okay, so this is an important advice, again, that we say to the patient, and let's have a look to this important table. Importance of excluding underlying pregnancy before initiating intrauterine contraception. Do you think that this is very important? Sexually transmitted infection, okay? So, sexual history should be taken prior to IUCD insertion. If the woman is identified as being high risk, she should be encouraged to accept STI screening. So you think that this woman is a high risk of developing STI because of her behavior, because of her age, or whatever, okay? So you give her the advice. What advice is very important before the IUCD? STI screening. Okay, guys? STI screening. Right? Right. If this woman have no symptoms of infection, you even examine the hair and there is no sign of infection, shall I wait the STI result to insert the IUD, or shall I insert the IUD in that time? you will insert. There is no evidence of infection in front of you. There is no symptoms, no signs, so no need to do anything. Just STI screen for just in case. Okay, send it for the laboratory and they insert the IUD. That's it. Shall I give antibiotic in this case? She is asymptomatic woman. No. Okay, if the woman is symptomatic, she had any symptoms of infection, okay, can I insert the IUD in that time? No, of course. So I will take swabs, okay, send for the lab, and if she needs treatment, I'll start treatment, and then after that, after she's clear, we can insert. Okay. If we speak about emergency contraception, okay, so my friend, if the woman require emergency contraception, remember here in an emergency contraception, okay, I'm not saying a woman comes to you to choose a birth control method. I'm speaking about emergency contraception. If a woman require emergency contraception and is symptomatic or at high risk, what shall I do now? Shall I send her home? I know that there are other options, but they don't, you know, discourage the use of the IUD because it's the most effective emergency contraception, especially that it can be used, you know, after the estimated ovulation rate, right? So in this case, you give antibiotic, right? And give antibiotic prophylaxis for the common STI and insert. Okay, guys? So in emergency contraception, and you have a woman high risk, give antibiotic and insert. Okay? Clear, my friend? So the situation is different between cases that comes to you in the clinic and between the cases of the emergency contraception. Okay. Uterine abnormality. Can I insert the IUD with uterine abnormality? Actually, I'll tell you, my friends, it's about which problem exactly, okay? However, some of the minor abnormalities or some problems, okay, it can be, you can still insert the IUD under ultrasound guidance, but it's not advised, okay? It's a reason, it's usually a reason not to offer the IUCD, okay? If the woman also have any distortion of cavity, this is associated with high risk of expulsion, so we don't advise it. Actually, it's one of the contraindications of use, relative contraindication, right? So according to the uterine abnormality, mostly we will say no, okay? Pregnancy. Shall I exclude pregnancy before insertion? Pregnancy, yes, I must exclude pregnancy before insertion, okay? Even if the woman comes to me outside the recommended time of the insertion of the method, even though, okay, what will I do? I will take a proper history from her about unprotected sexual intercourse, and I will see when was that. Okay, so history is important and UBT also is important, but the history of unprotected sexual intercourse even is more important because sometimes the lady had unprotected sexual intercourse 10 days ago. It can be too early, okay, for the pregnancy test to become positive sometimes, okay, or the woman had a multiple episodes unprotected, still she's at high risk, Okay, still UBT is not positive, still early for the UBT to be positive. So it's not only the UBT, it's UBT plus history, okay? History of unprotected sexual intercourse. This is very important for you in the part 3 when you counsel the patient, okay? Not much about the part 2, it's about the part 3. Healthcare practitioners can reasonably no, Dr. Mustafa, it's all about the excluding pregnancy. So if the woman is menstruating at that time, so no need by the history. Okay, but we are worried about the woman who presented to us outside the 5 days of menstrual cycle, okay, or the first 5 days post-abortion, or 20 days postpartum. We are worried about those patients who are outside the recommended period of insertion. Here are the criteria. So to make sure that the woman is not pregnant, she had not had sexual intercourse since the start of her last menstrual period, or she is within the first 5 days since the childbirth, abortion, miscarriage, ectopic pregnancy, or uterine evacuation for gestational plastic disease, that she has been correctly and consistently used a reliable method of contraception. Okay, so if she comes, this is for the outside the time. She's within the 5 days of the onset of normal menstrual period. If she is less than 21 days postpartum, she is fully breastfeeding, amenorrhea, and less than 6 months of postpartum, no need for UBT. She has not had sexual intercourse for more than 21 days and with negative urine pregnancy test. Okay, but if she had intercourse within that time and UBT is still negative, no, I'm not sure if she's pregnant or not. Okay, so when you are not certain about the pregnancy, don't insert it. Those for the patient who had unprotected sexual intercourse, multiple episodes or more than 5 days ago and less than 21. Okay. Okay, when you insert the IUCD, regardless of the setting, remember the following. Establish whether the reliable method of contraception was used before, obtain consent, written or verbal. Okay. Keep written documentation, including finding of bimanual and speculum examination. Provide post-insertion information. Okay. Insertion technique for different intrauterine contraceptive like Mirena, Jardus, and Kyleena. Okay, they have the same insertion, technique. Once loaded, these devices cannot be reloaded if the initial insertion attempt failed. Levocert is two-handed insertion technique and can be reloaded on a sterile field and reintroduced if the first attempt is unsuccessful. So this is one advice of the one advantage of the Levocert over the Mirena. Intrauterine contraceptive is in non-contraceptive setting. Okay. This is one point that I need you to know, my friend. And this point is also in the TOG article of the contraception around menopause. That if the Mirena is inserted at the age of 45, okay, it can be used as a contraception and management of HMB for 7 years or longer if the woman remain amenorrheic. How? I'll tell you. Look, my friends, you know that if the woman had Mirena, and again, Mirena had some other treatment or some health benefit other than contraception, right? She had heavy menstrual bleeding. And then she had Mirena to treat the heavy menstrual bleeding. After 2 years, she came to you. Doctor, okay, I am now 47 years. Okay, I had Mirena since 3 years is there. And now I don't have period at all. Now I don't have period at all. What's your advice for her? Could you please tell me what are you going to advise? 47, she had Mirena mainly for the treatment of HMB 3 years ago. Means that when she was 44. Okay? and now she's amenorrheic. Okay, so we advise that the woman who had amenorrhea on hormonal method before the age of 50, that she continue on the method for 2 years, right? You remember this? Yes, that's good. Okay, so that means she will stop it at 49, you think? Okay, how about the therapeutic goal of it? It was for HMB. And now we are not sure. This woman is amenorrheic because 1 in 5 in the patient of patient with the Mirena will have amenorrhea after 1 year of use, or she reached menopause. So it will be more safe to continue on using the Mirena for 7 years, till she completed 7 years. Okay? Okay. So, especially if at the age of 45 or more. So, now she had the Mirena, it's already in place. She had it for the treatment of HMB and also contraception. Now she is amenorrheic. Okay, so can I use it for 5 years and then remove it, or remove it today, or continue 7 years? Which one you want? Remove it once she completed 5 years, or remove it today, or 7 years? Continue for 7 years. Why? Because the therapeutic benefit, okay, of it is still working, still valid. Okay, because the therapeutic benefit of it for the treatment of HMB is still valid. And by the way, my friend, it has some other benefit. It will protect the endometrium. The women who have HMB, we don't know why. Maybe hyperplasia, maybe anything, maybe very small fibroid, maybe adenomyosis. She had some problem. That's why she had HMB, right? Even if unexplained to us, but there is a problem, right? So it's better to continue for 7 years for the treatment of HMB, okay? So Dr. Afnan, if she came to you at 47, she had the Mirena for the treatment of HMB, okay? For the treatment of HMB, can you use it when she will remove it from 47? At the age of 52 or at the age of 54? If she inserted at the age of 47 for the treatment of HMB. Not 52, Dr. Iman. This is what we say, 7 years. 7 years. Okay? They said, okay, that even up to 55, it's okay. Okay, guys? So don't worry about the extra use, the extra years of use, right? So 7 years, if it is inserted in woman 45, so if you have a lady in your clinic, her age is 45 or above, she had HMB, insert Mirena, and don't remove it when she got a menopause. No, leave it for 7 years. It's okay? Clear, my friend? Leave it for 7 years if she had HMB. She will benefit from use of it. Okay? Okay, so here some notes. Emergency contraception, the copper IUD is the most effective method because it's the only one that's effective after ovulation has been taken place. Okay, all eligible women requesting emergency contraception should be offered the option of copper IUD. Copper IUD can be fitted for emergency contraception up to 5 days after multiple acts of unprotected sexual intercourse, or up to 19 days of at regular 28 cycle, and provide ongoing reliable contraception. Okay? Okay. Contraception post-pregnancy. LARC is associated with high continuation rate at 12 months post-pregnancy. Okay? The IUD can be inserted up to 48 hours post-delivery, including the time of lower segment cesarean section, with no increased risk of perforation if it is inserted post-delivery immediately. However, there is increased risk of expulsion rate. Okay, so it's not perforation, it's about expulsion. Women should be encouraged to attend thread check 6 weeks after insertion. Contraception in a woman age 40 and above. If the copper IUD is inserted at the age of 40, it can be used as effective method of contraception until menopause. Okay? If Mirena is inserted at the age of 45 or above, it can be used for contraception and management of HMB for 7 years or longer in women who remain amenorrheic. Once a woman reaches the age of 55, contraception can be stopped. Okay, guys? Contraception for adolescents. The copper IUD is an effective option for young women, particularly if there is no ongoing dependence on the user once the device is in place. When counseling adolescents, it's important to discuss pain relief options available and the importance of using condom for safe sex. Use of the contraception for non-contraceptive benefit. What is the most important non-contraceptive benefit? Heavy menstrual bleeding, right? What about if the pregnancy happened? When? Where the pregnancy happened? Was, surprised by the question. Tell me, Dr. Amal, do you mean when the pregnancy happened on the IUD? Yes, counsel the woman about removal, okay, because if it retains, it has high risk of infection and complication. And when it is removed, okay, it will also have high risk of miscarriage, okay? But miscarriage is better than staying in the uterus and cause severe infection or complication or perforation. Okay, so counsel the woman about removal of it. Just inform her that there is higher rate of miscarriage. If she decided to leave it, high rate of infection and pregnancy complication. Use of contraception for non-contraceptive benefit again. Heavy menstrual bleeding, my friend. The Mirena is the first-line treatment option for a woman have HMB with no significant pathology. This includes women with adenomyosis and fibroids at less than 3 cm in diameter and not distorting the cavity. Women using Mirena for HMB only can retain it for as long as it continues to control symptoms, okay? So if she had, again, Mirena for HMB, it can be stayed more than even 5 years, especially if the woman more than 45, okay? Menopause management. Mirena is good option for HMB, especially in the perimenopausal period. This is because there is additional option used in the progesterone arm of the menopausal hormone therapy. What is this? What is the use in the hormonal menopause, in the menopause management, HRT? You can use the Mirena as progesterone and offer estrogen by implant, for example, estradiol implant, okay, or gel or patch or spray, any other form of the estrogen, even oral estrogen pills, okay? But usually if the woman have it there and she had HMB and she had perimenopausal symptoms like hot flushes, less libido and problems, just add estrogen, that's it, okay? PMS, okay? There is no evidence to support Mirena alone to treat PMS, of course, okay? It's unlikely to inhibit ovulation. And the most important thing, guys, that a woman with PMS, she has sensitivity to progesterone, so don't offer her progesterone alone. The advice is if you give it, okay, for a woman in the treatment of PMS, and of course, it is not like the first choice, you will offer estradiol as it at the same time, right? Right? So estradiol patch, for example, with micronized progesterone, or Mirena as alternative for the progesterone. Reduction in endometrial hyperplasia. We have studied this, right? We don't need to read this anymore. Troubleshooting situation when there is a difficult in removing the intrauterine contraceptive. First line investigation is if the threads are not visible. So what you will do? First line investigation is transvaginal ultrasound to confirm the presence of and the position of the device. Excellent. Okay. An X-ray of the abdomen and pelvis should be done to exclude perforation if the IUD insert not found on the ultrasound. Okay. So ultrasound first. Then, if not found, X-ray of the abdomen and pelvis. If perforation is confirmed, then laparoscopy must be arranged to remove it. Okay, guys? Otherwise, if you didn't find it in the TVS and you didn't find it on the X-ray, it's not there, right? It was expelled and the patient didn't notice. So you have to take a proper history, sexual history, and provide emergency contraception if she's at risk of pregnancy, right? Mirena is more stable, okay, less risk of expulsion than the copper IUD, okay? But if you're not sure about the presence of Mirena, you have to do, okay, the investigation also to make sure where it is. It's must. But it has less risk. The common problem like this happen with the IUD. If the device is identified and removal is requested, okay, Spencer Wells forceps can be used to explore the cervical canal. So if you find the device by the TVS, okay, and the thing is that you didn't find the threads, okay, or the position of the device is not correct now, okay, it moved somewhere. So you need to remove it. You find it by the TVS that it is there, you confirm it, that the device is there. So how to get it? First, try Spencer Wells forceps that can be used to explore the cervical canal, okay? This is more effective than using the thread retrievers. If unsuccessful, Hartmann alligator forceps can be used to retrieve the device from the endometrial cavity. But you have to give, of course, cervical block or otherwise, okay? If the woman had any narrowing of the cervix, she might have a shock. If this fails, the patient should be referred to outpatient hysteroscopy to remove the device, or for removal under general anesthesia, depending on the patient's choice and the previous experience. Threads may be difficult to see in a woman whose insertion was associated with suboptimal placement, following by migration to the fundus. Taking the threads up with the device, okay, so it will be more difficult. The Faculty of Sexual and Reproductive Health guidance is that the ICD located 1 to 2 cm from the fundus can retain in situ rather than being removed and replaced. Okay, so if you are sure that it's 1 to 2 cm from the fundus, okay, keep it in place. No need to remove it. Okay, my friends? We have done with this TOG article. Just please give me 1 second so I can change my presentation, please. Hello, my friends, and welcome back. I have posted to you guys on the group the consent advice. Have you seen this before? You should have studied during the surgery module, right? Yes, I think you should have, right? Okay. Yes. So it's some questions on the sterilization comes from this. Okay. It's not in the group before. I just posted there now. Before it was in the surgery file. Okay. It was in the surgery file before. You're welcome. Okay, so guys, in order to summarize for you, okay, about the sterilization, the FSRH has a very nice summary, and they like to ask a question from it. Okay, about the so we will have some interesting information there. Okay. The written consent should be obtained from individuals wishing to undergo vasectomy or laparoscopic or hysteroscopic tubal occlusion, right? So it's about the written consent. Consent form and the clinical record should be used to document, okay, the agreement of the procedure. Legal advice should be sought if there is any doubt if the person has the capacity or not. Okay, so it's very important. Why? Because my friend, the law, okay, states that you don't have the parent or the carer of a person with mental capacity questioned or reduced mental capacity, okay, they can't sign for the sterilization, okay, procedure. So it's not about a young girl, her mother brought her and she's 16 or 14 and she wants you to sterilize her. Okay, can we take the consent from the mother? No, permanent sterilization is not the right of the mother or the carer of that young child. Same for any woman who had mental issues at that time. If a woman had mental issue, can anybody come to you, like her husband or her parent or her brother or anybody, and tell you to do a sterilization? No. Okay. iOS has no problem, my dear. iOS has no problem because it's not for sterilization. I hope that we differentiate between both conditions. Taking away the person fertility, okay, it's a method like hysterectomy. Hysterectomy is not allowed without a court, order. So the doctor must obtain legal advice before he say anything in this regard. Okay, this is a very common question in that part, you guys, and it's repeated in some of the publication. It's repeated in a TOG article. It's repeated in the guideline. So we don't have any excuse to answer it wrong in the exam. Okay. So pre-sterilization information and advice. What I need to discuss with a woman or a partner came to me, okay, both partners came to me and they requested sterilization. They need to understand the procedure. They need to understand, okay, the decision, the consequences of this decision. If they have been counseled enough about the contraceptive methods or not, especially the LARC. So why shall I go for a procedure that it's a surgery, okay, if there is a LARC? So we have to discuss all of this, okay? And sometimes, if, for example, for some medical problems, like a woman had a cardiac condition or something, she wants to have a sterilization, okay? In this regards, if she is in a stable relationship, she is married and her husband is there, they both agree that they don't want more children, she is at risk of pregnancy complication because of her cardiac condition. So I can discuss with the male, why not have a vasectomy, right? So even first, I will discuss LARC. Then if they are in a stable relationship, okay, I can discuss vasectomy with the male. Why vasectomy is preferred by the guideline than the female sterilization? Why do you think? First of all, if we compare between male sterilization and female sterilization, we find that the female sterilization failure rate is very high. Overall failure rate is 1 in 200. Okay, so it's not a good method. There is still a risk, not very good method. So if we speak about male sterilization risk or failure rate is 1 in 2,000. So it's 10 times safer than the female sterilization. This is one thing. Another thing is, it's outpatient procedure. The male sterilization is outpatient procedure. However, the female is a laparoscopy, right? General anesthesia, laparoscopy with the complication and everything. Plus, reversal of the male sterilization is easier than reversal of the female sterilization. And actually the female sterilization, according to the technique, it can be even not, the reversal is not available, or it's not an option. Or even if you do a reversal, the success rate of pregnancy afterward is not high. So it's a problematic if the woman decided, to change her mind in the future. So we need to discuss this point with the lady. Also, if you have a female, especially if she is young, like she is less than 30, okay? Less than 30, she still have more than 10 years in her fertility life, right? She might regret this decision and wish to have a pregnancy in the future, right? So they said that higher regret rate in this age group. So we need to have a good counseling, right? And it's all about availability of alternatives, risk of the procedure and risk of failure, plus the regret, okay? And the re-sterilization, is it available or not available for the procedure? Plus also that the re-sterilization, if the woman insisted on the sterilization after this, it will not be on the NHS. It will not be funded. She must go private. And if she went private, this will be very expensive, right? So she need to understand this information, guys, very well. So this is about that pre-sterilization information and advice. Alternative sterilization and the contraceptive method, we said all verbal advice must be supported by printable or impartial material. Okay, you give them patient information leaflet, and if the woman speak another language than English, give her a translated one, okay, because the translated patient information leaflet is available. Okay, so give her the appropriate information as a part of your counseling. Counseling and advice of sterilization procedure should be provided in a woman and men within the context of service providing a full range of information about this advantage, disadvantage, and the relative failure rate of each method. Both vasectomy and tubal occlusion should be discussed with women and men requesting sterilization. Actually, my friend, it's more of part 3 case, and very, very important case for you in the part 3, inshallah. Okay, but for us now in the part 2, what is the most important point for the exam? Okay, the questions will be about the procedure itself. Okay, so where to place or to do the sterilization or to insert the clips. Okay, and about the failure rate, this is a very common question. So let's see the important points for you in this guidance. The regret, again, remember, it's for the individual under the age of 30, okay? And the woman should have a good counseling and agreement at least 2 weeks before the procedure, okay? in this guidance, okay, here they provide information about the tubal occlusion, okay, and approach to the fallopian tube, my friend. Cholecystoscopy should not be used as method of approach to sterilization. This came before in the exam as one of the options. Can I use a cholecystoscope? Can I use it or no? You enter via the cul-de-sac. Can I do that? No, it's not advised. How about laparoscopic approach? Yes, please. Okay? Okay. So the woman should have information about the risk associated with a laparoscopy, okay? And that sometimes it may proceed to laparotomy. Okay? Okay. The occlusion methods. This is what they ask about. And any effective surgical or mechanical methods of tumor occlusion can be used when a mini laparotomy is the method of approach for interval sterilization. For postpartum sterilization, both Filch clip and modified Pomeroy technique are effective. Filch clip application is quicker. Mechanical occlusion of the fallopian tube by the Filch clip should be the method of choice for laparoscopic tubal occlusion. Okay, so in the exam, they give a very direct question about the use of laparoscopy, laparoscopic approach, and about the use of the Filch clip. Okay, guys? Can I use more than one Filch clip? No, it's not advice. Okay? Anesthesia and analgesia. Of course, if you are going to do a laparoscopy, how we will do it? General, right? Okay, how about the benefit of topical application of local anesthesia to the fallopian tube? They found that they stopped, Dr. Abir, they stopped the hysteroscopic sterilization in the UK. It's not done anymore. And you should be updated of this piece of information, okay? That we don't use the hysteroscope, the hysteroscopic sterilization anymore. Now we come to the point again, guys, for the topical application of local anesthesia to the fallopian tube. Okay, what is the benefit of application of the local anesthesia? This is an exam question. What is the benefit of the local anesthesia while you're doing the procedure? It will reduce the post-operative pain. Yes, good. Yes, it will reduce the post-operative pain. Okay, so what about the failure rate? Failure rate, lifetime risk of laparoscopic tubal occlusion failure using mix of occlusion method is estimated to be 1 in 200. This is a very common number to be asked. The longest period available follow-up data for the most commonly used method used in the UK, the Filch clip, suggested a failure rate of 2 to 3 per 1,000 procedure at 10 years. Okay, so hold on. In exam, how can I differentiate between the two numbers? Simply, if he give you lifetime risk, the whole lifetime risk of laparoscopic tubal occlusion is 1 in 200, guys, right? Okay, if I told you about the Filch clip specifically at 10 years, do you think that the number changed? Yes, 2 to 3 in 1,000. Okay? Is that clear so far, guys? Yes, it's clear, alhamdulillah. Okay, so my dear friends, I would like to ask you to have a break at the moment, okay? So in order to save our time today, and what are we going to do after the break? We are going to solve the questions, and with the questions, okay, I'll show you some of the common recall questions about the contraception and about the STDs, okay? And that's it. There is no other, details. It's not about eMRCOGs. It's not about taking decision in eMRCOGs, okay? So we will have a good break for the mock test. It will be around 20 to 25 minutes, okay? And then we'll come back.